Okay, since it is 5 o'clock, I'm going to get started. So for those of you who are not my students, my name is Dr. Estes, and I am the core instructor faculty here on the Dallas campus. And I teach our patient exam 2 here in Dallas. So for my students that are on, they know kind of how I tend to run these review sessions in that I really prefer that they be student-led to answer questions versus me sitting and lecturing. I do have slides I can give, but they're very, very, very summative, not very specific, because again, I want this to be an opportunity for people to ask questions regarding units 4 and 5. So anybody can start, anybody can go ahead, raise their hand, ask a question. I just prefer, if you can, to be on camera at that time. And this will be just kind of a free for all. You can come and go as you would like, but I am open to questions. So we're going to focus on units 4 and 5 today. Some of you probably haven't even gotten to unit 6 on your campuses. I'm not sure, but that's why we're going to focus on those other 2 units. And I will monitor if people have their hand up. For those that don't, though, if I don't call on you after a couple minutes, go ahead and just start talking and feel free to ask what you need. Does anyone have any pressing questions about like the ICU? We can start there. So the ICU in unit 4. And if no one has questions
So,
after, oh, I'm sorry,
uh,
go ahead.
I have a question about the lines and leads. Is there anything specific about that we should focus on?
So for this session, Brianna, I'm not going to give specifics about the exam because I don't know how the instructors on the other campuses lead that information for the exams, but do you mean for the ICU specifically?
Yes, for the ICU.
Okay, let me pull up a couple of items for that. Give me 1 second. And everyone, just give me a few moments as you ask your questions. I want to pull up the specific handouts and things to share. Um, so sometimes it'll take me a minute or two. So what I would say for in general, and again, not diving into the exam specifically, but in general for your lines and leads, I think that one of the nice things is the ICU will cover some specific ones that are more related to that setting, but there are also lines such as IVs, nasal cannula, oxygen that will be um, relevant across acute care, all the other settings. So for lines and leads specifically, I would know your general ones. So what an IV does, right? What your nasal cannula does. Um, I'm going to share my browser actually now that I have it up. That is not the screen I wanted. So this is your PowerPoint from, or your handout from this unit. And it talks specifically about the central line and PIC line. You need to know those moving forward throughout their curriculum and kind of what they do specifically, as opposed to what does an IV do. So, your IV is usually administering medication and fluids. Um, the G tubes and PEG tubes, that's going to many times be your way of getting nutrition if you are unable to swallow, or you are ventilated, whatever it may be, and you have restrictions on normal swallowing, you're going to use these other means for gaining nutrition. Um, Nasal cannula is the most traditional. If y'all think about, if you've had the experience of seeing someone, the strip in their nose that goes around their ears, that's your basic nasal cannula. That's to administer oxygen up to a certain amount. And then if you go into this unit specifically, you will learn about a ventilator. So a mechanical ventilator. You do need to know about ventilators, as they are a specialized piece of equipment that if you work with patients on a ventilator, you have to be trained on how to appropriately manage the ventilator. Um, and then the ICU lecture specifically does include a few other specific devices, such as the intracranial pressure monitor, so an ICP monitor. Um, they also talk about the PCA pump there. So, your PCA pump is what we many times think of as our pain pump. Um, it is inserted, and then within that pump, you also have a button that you can push to administer the medication on a PRN basis. Now, they do have these pumps usually timed to where if you push it in a certain period of time, you may not be able to get that medication again until, 2 hours later, or you might have to wait an hour later. So it's very specific to the individual and the medication being administered. Um, these two describe the differences in your G tube and your PEG tube. Again, with this section, I would know just the general of what are these doing for you? What are they administering to your body? So these kinds of tubes are going to be how do you get nutrition? Again, if you can't swallow, or you have any sort of blockage of your airway, this is how we can get nutrition for someone that might have those issues. Okay. So again, I don't want to necessarily dive into the exam because I'm not going to step on the toes of my colleagues on other campuses and how they provide that information. Um, but this is a really nice handout that I would recommend knowing. You will utilize this in your future courses, such as acute care in the fall as well, and in neuro. Um, the nice thing is, for the most part, once you move into units 5 with inpatient rehab skilled nursing, there isn't really many additional lines or leads. Most of the time, you're going to have less. So as I go from ICU to a normal acute care floor to inpatient rehab to skilled nursing, generally, I'm going to decrease what's on my body, in my body, things like that. That's not always the case, but for the most part, that's the progression, is to get rid of more and more of those lines and leads. So without directly answering your question, Brianna, does that help a little bit?
Yes, they helped out a lot.
Okay.
Thank you.
You're very welcome. And I do apologize because I don't know what other campuses have. I do think as a course team, we talked about this. Most of y'all have not probably seen a wound vac. I don't think we do not have one in Dallas. I don't think Chasm has one. Maybe not Florida St. Augustine, but regardless, if I tell this to my students, if you guys need further pictures, information on things that you can't see, I really do recommend looking some things up on YouTube. Just like a lot of healthcare videos, they'll show what the different types of equipment look like. So, like, for example, a wound vac. This is an example of a small wound vac. There are much larger ones. And if you need a better visual, looking those things up, using your resources online, ChatGPT, whatever it may be, just to get the visual information is helpful.
I have a
All
quick
right.
question if another
Yes,
person wasn't in line to ask.
I didn't see anyone, so go ahead, Ashley.
Okay, thank you. I appreciate it. So I think we're on like one more unit ahead. I don't know if y'all have gotten to it, but we're talking about like SNFs and outcome measures for that and home health outcome measures.
Mm-hmm.
So for the SNF outcome measures, we have like the 6 minute walk test, 10-meter walk test, Berg balance, FGA, ABC, and 5 times sit to stand.
Mm-hmm.
Like that's for the neuromuscular, and then we also have the MSK outcome measures.
Mm-hmm.
That's like the dash and the lower extremity ones.
Yep.
And so those are for the outcome measures for SNF, and then the outcome measures for home health. I don't know if I have this right. Is it the chief test and the FABS M test?
Um, Let me go to the outcome. So not every campus has probably gotten to this
Okay,
section. So I'll briefly touch on this. Let me look real quick though.
I appreciate it. Sorry, that was a
Yeah.
loaded question.
No, it's okay. Um, yeah, so these outcomes that they're talking about. So let me answer the short answer and then I'll give you a more extended answer. The outcomes that you were just talking about are environmental assessments specifically. So
Yeah.
they're not your traditional outcomes you think of in that these two, and let me share the screen real quick. And for campuses that haven't gotten to this yet, don't worry about it till you get to this, um, which should be this week. But so for example, here in home health, they talk about a variety of tests and measures. A lot of times we're focusing on these, right? Functional tests and outcomes. This environmental assessment on the top there, that's what those two outcome measures specifically are talking about. And the reason is now I've never worked in home health. I have worked in outpatient, acute care, ICU, inpatient rehab, but not home health. But a home health therapist will do an environmental assessment because they're the ones that get to go to the patient's home and assess, the barriers or what might need to change to make everything a little safer and more accessible. So these are just examples of two outcomes that are specific to the environment in order to assess, like it says, the environmental barriers, support mobility restrictions within the home due to that. What you can do with those then is, possibly use that in conjunction with other personnel to help facilitate how can we either get this person's home environment to be safer, or what potential barriers might they face that we need to keep track of that maybe we can help improve from a non-functional standpoint. Okay. So that's what those are really looking at. It's not just going to be related to their PT, it's really the safety of their home, or can we justify, and this is a reach because a lot of insurances won't cover home modifications, but are there ways we can justify that this is unsafe and maybe they need to reach out to insurance or the VA if they're veterans, so on and so forth, to get things changed? hmm hmm And this also helps us keep track as therapists, to make sure that we did our due diligence to assess the safety of their home and see if they're in an okay situation, living situation.
Does the OASIS count as an outcome measure since we're assessing the
The
ability?
the OASIS is the EMR system. So the
Okay.
OASIS has outcomes and tests and measures within it, but the OASIS is like the entire, um, it's you're going to do outcomes within that. The OASIS itself is more of the entire system and like the intake, it includes everything versus us as PTs, we're still going to do our own outcome measures and assessments that are separate, if that makes sense.
So with the Oasis, we can do like a tug test.
Yep.
Or
Oh yeah. Yeah. So now let me get to part of the other kind of half of your question. So when we talk about, I'm going to go out of this and go into, actually, I'm going to share that one again because there's a good. So when we talk about outcome measures, in all of these sections, we do specifically talk about certain outcome measures, and each setting has presented a list of outcome measures relevant to that setting. However, you might notice that, okay, let me share this bigger now. You might notice that within each setting, some of the outcomes exist in the other settings. For example, the tug is not just an outcome that I can use in one setting. The tug has been studied in different populations and studied in different settings. So some of these are going to be listed under, you know, inpatient rehab, outpatient, home health, whatever it may be. There are outcome measures that are specific to certain settings. For example, there are certain outcomes in the ICU that are ICU outcomes. And what that means is once you leave the ICU, if you use that outcome outside of that, it has not been compared to other populations in other settings. So you cannot take that data and compare it to the studied population. Most of the outcomes in the ICU, you're not going to do beyond the ICU. There are some outcomes that you might do in acute care in general. So like the Boston AMPAC 6 clicks, that's a very common outcome measure in acute care. I'm not doing that outside of acute care. While I do that outcome measure, I may also do a FIST, so function sitting test, assess them there. And then when they go to inpatient rehab, I might do another FIST and see if they've made progress within that or if it's still relevant to them. Maybe I have a higher level patient in acute care that I can do a 6-minute walk test because they were someone that had a cardiac event and I'm looking at their endurance. I take that and then they still need rehab. So they're going to go to inpatient rehab and they're going to get assessed again with the 6-minute walk test. And guess what? Maybe after that, they're still needing therapy and I can do that in home health or OT. So some outcomes are really across the board. We go over some of the more common ones. The ones that are specific to each setting usually have the name in it, or you won't see it listed in those other settings within our presentations. And again, most of the time, that's because it's an ICU outcome. Acute care has a couple specifically that are studied in acute care and not other settings and really don't aren't relevant for other settings. For the most part, though, there are outcomes you can use across the continuum. And it actually is really nice to be able to do that because you can see the progress across the continuum. Now, we give you these lists in your presentations. However, just so you know, and I told my students this, if you haven't gone over certain outcomes yet and you're curious about them, you can go to Rehab Measures or Shirley Ryan online, and that has the database of all the outcomes. Give me a second, I'll show it to you. I'll actually share it on my screen or on the screen that you can see. So this website, it used to be called Rehab Measures because before Shirley Ryan became what it is, it was the Rehab Institute of Chicago. When you go to the APTA website, this is what they're going to refer you to most of the time for outcome measures. So when you go to Rehab Measures specifically, it'll give you this tool here. You type in walk test. I'm just going to use 6-minute walk test as an example. I'm going to click on it. The really nice thing about this is it gives an instrument link so it can tell you exactly how to administer it. It's going to show you the diagnoses that it has been studied and validated in. So it's going to provide you the psychometric information that has been obtained or attained for this measure specifically. So I'm going to scroll down. Here are the diagnoses. Here's the descriptions, the instructions, the equipment I need. And then they do update this pretty frequently. It's going to talk about, let's go down. So it's going to give information on what settings you should use it in for what diagnoses. So HR means highly recommend, R is recommend. Let's see. LS, you are unable to recommend, and that's just because there's not enough studies to dictate if we have good information on it in that setting. And then NR is not recommended. So they have done the study and it is not recommended in this either population or this setting. So I always push people to this resource when you have further questions about it, if it's good for that setting. And you'll see a lot of them are across the board, like recommended. So for this, remember, is a 6-minute walk test. It is recommended in acute care, inpatient rehab, a SNF, outpatient, and home health for stroke persons with stroke. It has some recommendations for someone with TBI in inpatient rehab and outpatient. It's not recommended in home health, and they don't have enough data really to say yay or nay for acute care or skilled nursing facility. So most of your measures, most of them are not necessarily specific to one setting, which makes it nice when you're trying to pick and choose. The other thing I do tell people is while you're making these decisions as novice clinicians and students, we want you to stick to what you're learning is this is appropriate, this is inappropriate. I will tell you though, eventually you will, when you're a clinician, you'll have the opportunity to, let's say, I work with someone that, let me go down here to where so they have a traumatic brain injury. Now, remember, a traumatic brain injury can be as something as mild as concussion to severe, minimally conscious, right? So that's a big span. If I have someone that has a concussion and maybe endurance is one of their limitations, or increased heart rate and is one of their exacerbating factors, even though it's not necessarily supported strongly in acute care, I may choose to do it there and compare them to themselves. Or I'm at a nursing facility. I know they're going to be there for a while. I'm going to do the 6-minute walk test day one, and I'm going to do it 2 weeks later. And even though I can't compare that to all the other brain injury persons that have been studied, I can say this person has gone from this to this within their own timeline, and that is improvement. So sometimes we'll use outcome measures against the person themselves um, to get more information and to at least support that they've been improving. So that's the additional information I wanted to give. That's kind of a long answer of most of the measures can be used in multiple settings. When you're studying, if you have one that you haven't seen, a lot of times it's probably because it's specific to that setting. If you are unsure, this is a really good place to look as a resource of, oh, it's only actually been supported in this study or in this setting. Does that help?
Yes, that helps a lot. Thank you.
Okay. Mm-hmm. Mm-hmm. Anybody else have questions that have come up? So I'm going to pull up. I did make a couple PowerPoints and I'll have Barbara post them so that y'all, for those who are here, these PowerPoints don't, they're literally summary PowerPoints. They're so brief because I really didn't want to lecture very much, but I'll show them to you at least. The thing that I've been telling our campus that I do think is really nice about a lot of these sections. So, your sections, the past 3 weeks have been pretty heavy on content, asynchronous content, right? 2 hours worth for most of the time. There are differences in all of them. However, for the most part, if you really look at how it's broken down, not much of the PT goals or what we're addressing, how we're performing our patient interview, like those kinds of things don't change a whole lot across settings. Yes, there are nuances and maybe a couple different questions you're going to ask, a couple of different tests and measures you might do, but for the most part, once you get into the rhythm of knowing what you're doing as a PT, you'll know what to look at in each setting. It's not drastically different. So this is just a summary of the ICU and long-term acute, LTAC, long-term acute care. So your chart review, and all of these are related to your course learning objectives. So your chart review in general, right? You're looking at the referral. When they're in the ICU, that's going to a lot of times what that looks like is your orders. So did your doctor order therapy? We want to make sure we have the orders. You're looking at your lab values. So when someone's in a more unstable state, acute ICU, acute care, long-term acute care, I'm really making sure I'm looking at their lab values. Now, I'm not saying you shouldn't always look at them, but ICU, acute care, especially long-term acute, you have to be more diligent about looking at them because that can make someone's performance stability fluctuate minute to minute. As someone that has worked in the ICU, you can go in the morning, chart review your patients, go in and see your first patient. And then before I go see that second patient, ICU or acute care, I'm still checking with the nurse and I'm probably going back and doing a quick search to make sure nothing has changed vital wise, lab work, whatever it may be, because that's how quickly things can change. And again, they're in acute care, so they're not stable enough to not be monitored all the time. So looking at their medications and any precautions that they have. You want to confirm their activity level. Do they have any precautions provided by the doctor? Are they able to do everything for a full evaluation and treat? And then are they due for any procedures? Are they getting a Doppler ultrasound on their lower leg in half an hour? If that's the case, I'm going to probably suspect that they're worried about a DVT. And at that point, I'm going to confirm with the nurse and I'm not going to see them right then and there because whatever they're pending might dictate whether or not they're going to end up being safe for me to see. So you're a lot more diligent with that in these settings. You're still going to conduct your patient interview. You're going to use adaptive communication if you need, which you're learning about in innovation and technology. And then you're going to take subjective history if you can. And tie all of that into your PT evaluation. So, let's see. I think Ashley was gone, but this is an example of maybe some of the ICU specific tools, right? These are used in the ICU. They're not really used much outside of that. But other than that, other than those specific ones, you get to choose based on their diagnosis, what equipment you have, what equipment you need. Are they conscious enough to do it and their tolerance? Okay. Administering your tests and measures, this is just like anything. You're going to make sure they're stable enough. You're going to follow any precautions they have. And then you're going to use whatever you get from the outcome measure to guide your treatment. Were they able to perform certain parts of it well and not the others? Do I need to then turn the things that they can already do pretty well into an intervention, or should I probably focus on the things that they can't, right? This last one, this co-treatment is more so in the ICU and acute care. Maybe someone can't tolerate much a day and OT needs to see him as well. Maybe we can both tag team it and I can do my evaluation, they can do their evaluation, and we serve as each other's second set of hands. And that does happen more often than not. Your problem list, this is your ICF model. This is going through your ICF model. What are their impairments? What are their activity limitations, participation restrictions, environmental and psychological or social barriers that might, or barriers or even positive factors that might influence what you're doing. This is talking about line management. A lot, you need to document what lines they have. If they're on oxygen, you need to document what kind of, how much oxygen they're on, so on and so forth. And you might need help with the lines. In an ICU that someone has a lot of lines, you a lot of times cannot safely mobilize this person without help. Talk about that with the ventilator a lot. You need help with the ventilator for safety most of the time more than anything. Gait, if they're appropriate. Some people in the ICU are completely appropriate for gait. We talked so much about interpersonal and interprofessional collaboration. We talked about SBAR a little bit. You will use that a lot. You're going to collaborate with everyone. SBAR is a really nice actual studied form of communication that keeps things succinct and effective across the board. And you're going to constantly be talking to the team about the goals and the discharge plan. Everyone contributes to this. It's not, you don't, as a PT, you don't decide the discharge by yourself. Okay. You have to be very diligent about recognizing signs and symptoms of an emergency in the situation. Hypotension, arrhythmias, whatever it may be, if someone's becoming more agitated or delirious. There are outcome measures to assess agitation, delirium, things like that are performed. A lot of times those are going to be performed by the nurse or someone else. Not all the time. You absolutely are able to that. But again, the ICU especially is a lot of teamwork. You're not doing things all by yourself and you're communicating constantly. You're always going to report something new to the nurse, the doctor, whatever it may be. For example, if I'm used to seeing, I know my patients, I've seen this patient the past 2 days. They've been doing well, they've been stable, they've been cooperative, and all of a sudden I go in and they're not able to follow commands. They're not able to stay awake. Something's changed. I'm going to let them know immediately because that could be a change in their entire status and their stability, and that's something that they need to know very quickly. This goes along in any setting, patient and family education. Okay, you're going to educate in any setting that you can, any and every setting, the patient and the family. You're always going to measure and track your responses to your evaluations, right? What that means is you're going to do your evaluation as you continue to see them. You're going to track if they progress or regress in their function. You're going to always be documenting how they tolerated treatment. A lot of times that's going to look at their vitals. They're laying down. This is what their heart rate is. I sat them up. It skyrocketed 20 more points. But it came down pretty quickly, or it continued to rise. They're probably not very stable. I might need to lay them back down and let the doctor know. But you're always documenting that stuff to make sure that the person coming in after you knows what they can tolerate, but also so you can keep track of what's going on with that person. And then you just reassess and adjust the plan of care as you talk to your teammates, other providers, so on and so forth, and you work as a team. So very brief summary, but that's your ICU. I hope that the trend you saw from this is you have to be very diligent, very mindful of the medical complexity. These are very complex patients. I spent a lot more time when I was in the ICU, probably doing my chart reviews and focusing on assessing the patient's reactions via their vital signs, things like that, than maybe in other settings where I was able to move forward more quickly because they're more stable and I don't have to stop and assess vitals all the time, so on and so forth. So just know this is a very complex setting and you're going to spend more time on some of the medical complexities and really knowing those. So that's your ICU summary. There's another one. And please interrupt me because if you have questions, I want those to be the priority here. Okay. Hold on a second. Okay. So this one's kind of a continuation. Your chart review, this is just an example of some labs. So your CBC, electrolytes, coagulation, kidney, liver function, these are things that are going to impact your therapy session. If someone has a low hematocrit and hemoglobin especially, they might be on hold. They may not be able to be seen. If they're now you might learn of norms in your book and things like that. Hospitals tend to have different standards. So one hospital might have a different standard than others. Different patient populations have different standards. There are some people who are going to run low, but that is more normal for them. And maybe they're allowed to be seen at a lower hemoglobin than others. Okay. Sometimes, and a lot of times, you're going to look at the trend of the values. Is their hemoglobin trending down over a couple days, which means, something's going on. If the doctors are watching that, fine, but maybe because of that, we're starting to notice a change in their performance in therapy because they don't have the energy anymore because they're becoming slowly anemic, right? Maybe their troponins are trending up. Well, that's kind of concerning because does that mean that they're actively having a heart event or they had one and this is the aftermath? I don't know. It's not my call, but I'm going to look at that and say, hey, I'm concerned about this. What's going on? This one's just talking about you want to, when you talk to the patient and their family, if they're not cognitively able, you want to assess their pain. And sometimes that's a questionnaire that you can ask them. Sometimes there are certain outcomes that you have to look at their behaviors and how they're reacting to things. They talk about the FLAC in there for someone with a severe brain injury that is non-communicative. I'm going to use the FLAC to determine if I think what I'm doing is causing pain. You look at their cognition, you're going to assess their functional goals. You can ask family if they have goals for them, if it's someone that can't communicate that. And then you're always considering the lines, tubes that may impact the participation. Where that is important also is before you go see someone, there are certain lines, tubes, devices that you have to, before you can go see them, the nurse might have to clamp off or change or disconnect or whatever it may be to make sure that they're safe. You might have someone that is on a ventilator and your goal is to walk them. Well, you have to coordinate that with other people to be able to serve them best. So you're not going to go in and walk someone on a ventilator without a team of people. It's not safe. It's not good practice. So these are things you're considering before you're seeing someone. Select and test the measures. We do like to look it up based on diagnoses. I'm going to try to use a measure that has been studied for that population, maybe more so than using one that hasn't been. I'm going to choose one that's good for their tolerance. This person's been in bed for weeks. They don't know how to stand. I'm probably not going to, at this point, they can't stand. I'm not going to choose a standing measure. I'm probably going to choose a seated measure. Okay. And then you're modifying your selection if the patient is on oxygen or there's some sort of monitoring because maybe that's going to impact how they perform. Maybe I don't want to do an endurance test right now. I want to do something else that gives them breaks or opportunities to sit because I'm not trying to assess their endurance. I'm trying to assess something else. So it's just looking at those different factors and how they're going to impact the performance. Monitor vitals, we know that, right? Collaborate with nursing. If the patient has suction or ventilation needs, you're always going to collaborate with the team for this, for safety. You're going to use your tests like your pulse ox, BP, ICP to guide your intervention. So I'm looking at these things to make sure what I'm doing is safe. And then you're documenting your patient responses and exertion level. If someone can't tell me how they feel, for whatever reason, and I'm working with someone in the ICU, I'm going to document their vitals as I do each thing. So when they were laying down, this was their BP, this was their oxygen, this was their heart rate. Once I sat them up, this is what changed. It took this long to get back to normal, or it continued to trend up. The patient became demonstrated signs and symptoms of orthostatic hypotension or decreased tolerance, fatigue, whatever. I laid them back down. That's a really good way for me to tell if someone tolerated what they did or not. Okay. Um, Developing your problem list. Again, I like to go through the ICF model, and you're going to take what you found from your examination, lab findings, and then recognizing your signs and symptoms of emergencies to determine, like, hey, maybe this person has orthostatic hypotension. And I found that out by going through the process of having them change positions. And that's going to go on my impairment list, right? Or maybe I sat them up and they were unable to sit without me holding on to them dependently. They have balance issues, right? Or they have weakness. I'm going to put that on my impairment list. Safe mobility. So with lines and tubes, things like that, you just have to be careful. If you aren't sure of a line or tube, you need to ask. Don't be afraid to ask if you haven't seen it before. Ask your colleagues, ask the nurse. Don't try to mess with it if you haven't seen it and you don't know what it is and you don't know how to handle it. It's much less safe to do that than just to ask and get help. Obviously, you want to avoid dislodging anything. Kinking it, if you kink certain tubing, it can change the function of the tubing. If you have a kink in a catheter and their bladder's starting to fill more and it's not draining, obviously that can cause some issues. Things like that are important to look at. Gait training, not going to dive into it, but assess their needs if it's possible at this point. Interprofessional communication, we've talked a lot about. This is the big thing that you probably haven't heard of until this course is the S-bar. There was an example of an S-bar in, I think, unit 5, unit 4, maybe. Either way, you're going to use your S-bar communication tool, and there is an example of that. Patient education in the ICU, a lot of times it's education to the patient family members on what you're trying to do in this setting. What are your goals? Why are we trying to get the person moving, 24 hours after whatever their incident was? Describing what immobility and inactivity can do and how much that can regress someone very quickly in the ICU. Discussing with the family, hey, like when I do this, this is what I'm watching for. I got to make sure I don't pull out this line or whatever it may be. And teaching them what you can to help. If it's a stretching program, to make sure that the patient maintains range of motion, since you can't be there all the time, teaching them how to do that and teaching them how to do it safely and what to look for and how to make sure that they maintain their and the patient safety during that. Again, measuring their response. And this is just specific to the ICU. So those are your ICU lecture. And then I just saw, are we able to get these slides? I'm going to send them to Barbara and have her post them. So yes, we should be able to. If for whatever reason, you can email me and I can send them to you if you don't get them from her in a couple days, okay? I'll definitely do that. And it's for Vero that asked that. any questions? Does anyone want to interrupt me, or do you want me to just keep going with these summaries? Like, how do you want me to do this? Again, I want to make sure this is useful for you. So if you don't want me sitting here lecturing and you have questions, that's what I want to address. If these summary slides are helpful, then I will continue. Okay, I will continue until someone says no. So long-term acute care. So you went from, oh, you know what? Yeah. You went from, so this is the only thing, it's going to be a little out of order. You go from the ICU, okay? From the ICU, which the ICU, as you've learned, is housed in an acute care hospital, or long-term acute care hospitals also have their own ICUs. So you have your acute care hospital and your long-term acute care hospital. Long-term acute care hospitals are usually these separate entities, right? They're still considered acute care. One of the big things about long-term acute care is that we expect this person to be here for greater than 25 days. And that's probably why they're being sent there, because we can anticipate that they're going to have longer needs than others. So we can put them in a specialized facility that takes care of them like an acute care hospital would be. Sometimes this is someone that's on a ventilator that's going to try to wean from the ventilator, someone that's getting long-term IV antibiotics, and we know they're going to be on them for a month. Rather than keep them in an acute care hospital bed, we can move them to a long-term acute care hospital, do all the same things. They get the same level of care. But that way they're there for a while, okay? Post ICU, basically we're serving the same persons that you would serve in an acute care hospital. Okay, they're medically complex, they're medically fragile, they're not super stable, they can't go home. They're not safe to go home at this point. You will see this a lot. A lot of people that are trying to wean from the ventilator, they'll send them here to start that process because it can take a while. Wound care, someone that has wounds that's going to need prolonged wound care, they can send them to long-term acute care. And again, a lot of times if they have bad enough wounds, they might be on IV antibiotics anyways. And then working on early mobility. A lot of times you're going to see those that are 65 plus with multiple comorbidities. That is not a hard and fast rule. You will still have young patients in long-term acute care hospitals as well. It's just this is pretty common. The nice thing is your chart review really isn't that much different. You're looking at all the same stuff. You're still looking at all their labs, their vitals, their lines and leads, and their notes, what they did for therapy, maybe when they were in the ICU, what their doctor's recommending. Do they have specialized precautions, or are there orders for a full PT eval and treat? Again, really nothing new to that. Same with your patient interview. You still want to get the same information as if you were in any other setting. Okay. Problem list. Oh, sorry, I didn't mean to jump ahead there. Same thing. Looking at the ICF framework. What are their impairments, activity limitations, participation restrictions, right? This is not drastically different. It might look different for that person specifically, but I'm looking for the same things. The ICF model is going to help me figure out what outcomes are appropriate, where can I possibly set my goals for, and what kinds of things are going to be limiting factors that I need to work around or work to improve. Goal setting, SMART goals are always what we're using, right? Specific, measurable, attainable, relevant, and time bound. Your goal setting in long-term acute care, you can set short and long-term goals because we anticipate they're going to be there for at least 25 days, right? Short-term goals, you're usually looking at a couple weeks versus long-term goals are usually 4 weeks. That's the example we give. That is not a hard and fast rule either, right? But you can kind of think of it in that way, okay? These two right here, this is a summary. These are not well-written goals. So if you wrote improved tolerance sitting or mobility, that is not a good goal. You cannot write that. But this is an example, okay? And your long-term goal is trying to achieve a lower level of care, whether that be that they go home and get home health, or they go to outpatient, or maybe they have to go to a skilled nursing facility for a while. Either way, we want to set our goals to get them to that point. Outcome measures. Now remember, LTACs do still have ICUs housed within them. So someone still could be in the ICU in a long-term acute care hospital, in which case I could still use the ICU outcome measures specifically. If they're not in the ICU, I'm not going to use the ICU measures. I'm going to use other measures that I might use elsewhere. The other ones that are specific more so to inpatient settings, the FIM, this used to be the standard for rehab. You had to use the FIM for everyone. It has changed, but most of the time we still use the same language. It's just a little semantically a little different. I'm not going to use the FIM in an outpatient or home health setting, okay? But the TUG, I might use that in any setting, right? You want to choose measures that are sensitive to change in the time frame that you're going to be there. For example, there are a few outcome measures that are not great for the clinic. Maybe they're more research driven, and that could be because, and I don't want to dive into which ones because you don't need to know that right now, but that could be because they're just not sensitive to change in the time frame that you would be seeing this person. Luckily for people that are going to be in a facility for longer, you have a lot more opportunity to see changes in that because they're going to be there for a while. Versus an outpatient, maybe I'm only going to see them for 4 weeks. I'm not going to choose an outcome measure that I wouldn't expect to give me significant information and changes in 4 weeks, right? I think that will come with time and experience on knowing what that is, though, what that looks like. You're considering all the same things when you decide to administer these tests and measures. Okay? All the same things when I'm moving them. All the same things with professional collaboration. All the same things with measuring the patient response, right? That's a really nice thing about some of this is it's not drastically different. Like I said, it's just you have to think about your setting and maybe you're asking a couple different questions. All right, I have a couple more of these presentations I will go through since no one's objecting or saying anything. I'm going to try to get it done in 8 minutes. That's the goal. So acute care and inpatient rehab went together in the presentations. So that's what we're going to do right now. So this one's more surrounding acute care versus inpatient rehab. None of this is different, right? I'm probably being a little bit more diligent in acute care. So when you go out of the ICU, you're going to usually go to the acute care floor. So I'm no longer critically ill or very unstable. I still need to be in the hospital because I'm not well, but I'm not as near death. And that sounds really harsh, but realistically, that's the ICU. The goal of the ICU is to keep them alive. So when I leave that critical state, I might still be unstable. I might still be very medically complex, but it's a little safer to put me on a normal floor where I don't need the astringent constant monitoring. I need monitored 24/7, but it might not be every second, every minute, okay? So they're still in the hospital. Tests and measures, you're going to select the appropriate ones based on the patient, what you know you can do in your facility, what equipment you have, and what's appropriate for that setting. You're going to administer them. So you're going to look at, remember, tests and measures are not outcomes, not outcome measures specifically. Your tests and measures are range of motion, sensation, vitals, things like that. I'm going to assess most systems with my patients, but I'm going to prioritize. So I'm a neurotherapist. I'm going to prioritize. So me saying that, I work on the neuro floors more than the musculoskeletal floors, right? Probably going to prioritize my neuro assessments to be first and foremost, probably going to do more thorough ones versus someone on a different floor that shouldn't have as many neuro impairments. Maybe I'm not doing as much there. And that's all just based on the patient populations you're seeing. You're going to use your objective data to guide your treatment and your discharge planning. Remember, discharge is not up to you. It is a collaborative effort between the healthcare providers and the patient. The patient has a say in their discharge because they might not have a safe discharge, at which point we have to find them a safe discharge. Or maybe they're refusing to go somewhere that you're recommending and we can't force them there, right? Monitoring vitals and patient behavior and incorporating whatever tools it may be. So this is a cognitive scale. This is the Glasgow Coma Scale is a medical scale, but we're looking at their level of consciousness after a coma. And then the FLAC is a pain scale for those that are non-communicative. Transfers and gait training, nothing really different. Are they appropriate? What can we do? SBAR, please look at that document. This is how we communicate. It is it's an objective way to communicate. It's succinct while also being thorough. And that's important. And the reason we need to be succinct but thorough is is of the essence. And a lot of providers don't have 30 minutes to have these conversations. It should really be done within a couple minutes. Here's the problem. Here's what I'm recommending, so on and so forth. Your problem list, that's your ICF model, right? Always monitor the response. And then recognizing the incidents and emergencies, situations where reacting fast is important will happen in this setting. And then I got one more and 4 minutes to get through it. And I do think I can do that. Okay, this one's really inpatient rehab focused. So I left acute care. I can tolerate 3 hours of therapy a day. So I'm going to go to acute inpatient rehab. So IRF, inpatient rehab, that's where I'm going. Okay. Well, I have to get a new assessment. I have to be evaluated by a therapist there. Luckily, that therapist is going to do all the same things that the therapist did in acute care, but this patient's just going to present differently than they did maybe a week ago. Okay. I'm going to do as a therapist what I know to do. I'm going to do a thorough evaluation. I'm going to check the things that are appropriate, test measures, outcomes, so on and so forth. The FIM is specific. The care tool is specific as well. So these are a few that are specific to that setting. Otherwise, I can do ones that I can do in other settings as well. The FGA, the DGI, I do those in outpatient all the time, but I also like them in inpatient if they're appropriate. Administering tests based on the diagnosis, the age, so on and so forth. All the same things, right? Transfers and gait, is it appropriate? How am I going to do it? What equipment do I need? What personnel do I need? My goal is to get them as independent as possible. Independent as possible does not mean independent. It means as good as I can get them. If they were not independent coming in here or haven't been for the past 2 years, if they've been walking with a walker, I don't think I'm going to set my goal to be to walk without a walker. Most of the time. SBAR, good collaboration communication tool. Your problem list, same thing. You're developing in the same ways that you did in all your settings prior. Okay. Monitoring your response, assessing the change before, during, and after your activity. Take all the vitals before, monitor them throughout, and then take it after. And that's going to give you a picture of what happened with this patient. Did they start off at a certain level? Everything increased, blood pressure, heart rate, how we would expect it with exercise, but it came back down and they recovered quickly. Or did it increase halfway through, never came back down to a safe place, and that's what they could tolerate? And I knew I couldn't push them anymore. Use your clinical judgment based on what you're seeing, not just what the vitals say. Yeah, their vitals are fine, but they don't look so good. Something else is going on. Maybe they're on beta blockers and their heart rate's never going to respond the way that it would with someone that's not on beta blockers, but I can tell something's up with them, right? And then adjust your goals and reassess if you need to, and you will need to. Again, recognizing things that are urgent, red flags, things that need to be communicated to the doctors immediately. Okay, that's a very quick and dirty rundown of the past few weeks. Are there any questions for those who are still on? Okay, thank you for coming. I believe Barbara will send these out. If not, you can always email me, Shannon Estes. I will send them to you. And it was good to have you all on here. Thank you for coming.